I'm going to talk to you about today is one of the projects that I'm working on. It's called the ETHN program, the Emergency Telehealth and Navigation program. And I'm going to talk to you about the comparative effectiveness of mobile telehealth technology in this ETHN program. And with me today is Diaa Alqusairi. Diaa is sitting in the second row. You're going to see him in a few minutes. He's going to help me co-present. Diaa, some of you may know, he got his PhD a couple years back from the School of Public Health. And he and I have been on at least 5 publications, I think, together. He's a really good researcher. And so he also is teaching now on the side, but he works with the City of Houston Fire Department in the EMS, and he's one of the managers that's implementing ETHN with the fire department. So not with me, but also part of this presentation from a CV perspective, at least, will be Mike Gonzalez. Dr. Gonzalez, some of you may know, he is a Baylor College of Medicine faculty, and he's basically the program director of what we're going to be talking about. Dr. David Peirce is the HFD medical director, and he's part of this project with us. Tiffany Champagne Langabeer, who you may know. Adria Jackson, some of you know in informatics. She's a PhD trained informaticist, and especially a nurse informaticist. And then Jenny McKyle. And Jenny's in the back, in the green shirt. And Jenny works with me day to day on this. So everybody's part of this. This is the project team, and we're presenting on behalf of them. Here's what you're going to learn about. So a lot of people in healthcare, and in our program at SBMI, and in the medical school, we talk a lot about hospitals, and we talk a lot about electronic health records. What we're going to talk about today is before the patient ever arrives at the hospital, that's called emergency medical services. And we're going to talk about something called a patient care record system, not an EHR, but a PCR. And it's very similar, but it's data that's collected prior to arrival. So I'm going to give you a little bit of overview to what EMS is. Has anybody ever been in an ambulance? Only one person? 2 people? Okay. 3? Okay. So was it on your own volition?
That was when we did the previous project.
Okay. So Lisa was part of a project. Luckily, none of you have been a patient, but I hope that someday you will be. So you can see how beautiful the ambulances are. So I'm an EMT, and I'm really into pre-hospital. I like that a lot. I like the emergency medicine environment. So I'm going to give you a little bit of background about this because most people know nothing about it except seeing the ambulances pass you on the street. We're going to talk a little bit about telehealth and something that we call in our field mobile integrated healthcare, MIH. And then we're going to talk specifically about the Houston Fire Department's ETHN program, what it does. We're going to show you, hopefully we have no glitches with the Verizon network, but we're going to actually show you what our telehealth platform is and how it works. And we're talking a little bit about the goals and the vision of it. And then we're going to wrap up with how is it working? And is it saving anything for the city and for the fire department and for our patients? And so we're going to talk about all that. So history and intro. Those of you the one of you in the back, I didn't ask what reason you were in an ambulance, but maybe you were a patient or a family member was. But if you think of an ambulance, what you might think of them for is to pick you up in times of great need during a trauma, a cardiovascular emergency, a stroke, you break your leg, and you needed to be immediately treated and you needed to be transported somewhere. And that's what they're known for. The primary goal is immediate medical care and stabilizing. So stabilizing is something very big. If you're bleeding and you're bleeding out pints of blood, we have to get that to stop. Because if we get you if all we did is pick you up, by the time you get to the hospital, you've bled out. So you've got to stabilize. The most important thing, and the reason I got into it, is time is critical. And I love time because time is something we can measure. Time is something we can always find a way to shorten. And so what we try to do in a lot of the EMS programs is find a way to shrink the amount of time that EMS is on scene and get a patient to what we call definitive care. And we try to do that in 30 minutes or less. Especially if you talk about heart attacks or strokes, time matters. Time is muscle. You hear that a lot. So we have some standards, and you've got to basically get in, diagnose the patient, treat immediately, get them in the back of the ambulance, and transport them as quickly as you can to definitive care. This is the typical ambulance, and this is our Memorial Hermann Life Flight ambulance, the air ambulance. What we're talking about with ETHN program pretty much involves these kind of ambulances, though. Okay, a little bit of history. EMS, the formal definition, the coordinated network of pre-hospital care for dispatching, treating, transporting patients outside of the hospital. So EMS, by and large, means all of the things that go on outside of the hospital. We tend to call it pre-hospital care. Oddly enough, even though EMS is medical care today, we think of it as medical care, it's actually governed not by the Department of Health, but by the Department of Transportation, and specifically within the National Highway and Traffic Safety Administration, NHTSA. So, and you had to think about why, which we'll talk about, but initially ambulances were all about moving safely on a highway to get the patient where they need to go. So it became much more about highway and patient safety, and it's evolved much more into the medical side, the healthcare side. So we have a lot of conflicting goals that we see from the transportation side as opposed to the medical side. And where it really started was Napoleon, and any of you who studied the French army would know that Napoleon Bonaparte, I believe that's how you say it, he had a surgeon, Baron Larry, Dr. Baron Larry. He's considered one of the godfathers of EMS. And what he said is, if on the battlefield I could get to a soldier, a wounded warrior, within 15 minutes of him being hit by a bayonet or a bullet, in 15 minutes I could dress that, I'll guarantee that he'll have a lot less safety issues and infections and a lot of other things. So he was the first one to ever set a goal for on the battlefield, 15 minutes, dress every wound. And so he had what he called the flying ambulance, the ambulance volante. Well, that sounded more Italian. I don't know how you would say it in French, but it's the flying ambulance. Get to the patients as fast as you can. And so he really created modern day EMS. Here's what it looked like. Tiffany and I watch The Nick. Does anybody else watch The Nick? Anybody ever heard of the TV series called The Nick? This is the most amazing show with Clive Owen, and it gives you the history of medicine. So those of you who really want to know where medicine started and healthcare and how clinical trials first initiated in the United States, you got to watch this show. But they have these ambulances back then, and so this was really the 1800s, 1870, 1880, 1890s. The horse-drawn ambulance started. For the most part, these people were not for treating, but for picking up the dead and bringing them into the hospital and bringing them into morgues. This is from the city of Vancouver, but every city started to get these kinds of ambulances then. But it really didn't go anywhere until the military picked it up. And this is much the case with almost all of our modern medicine. We really evolved because of military applications of things. And so in World War I, we developed the triage concept. And triage really came to me jumping on something immediately, figuring out what it is, quick diagnosis, and rapid treatment. And so then the transport concept. And so if you think about the way the medics started, a lot of people were running out to the battlefield, picking them up, and bringing them back to someone else's surgeon who was trying to fix them. And in Vietnam and Korea, new concepts came about. We started using helicopters to get to people. We also had field-based medical care and the MASH units. Anybody ever watched the MASH TV series? A few of you?
Before they were born.
Yeah. Anybody, so many of you younger people, have you heard of MASH? Okay, Mobile Army Surgical Hospital, I think it stands for. But MASH was really the concept of you put a hospital at the front line where the battle ensues, and you're going to get most of your patients. And so you're treating people as quickly as you can and moving on to the next one. And then trauma. We developed all of our modern day trauma standards because of what we saw in Vietnam and Korea. And all of the systems of care, we talk about trauma systems, they came from the wars. Okay. Military use really showed us we had the greatest potential. Civilian EMS was still primarily transport, but then in 1965-66, a published paper came out by the National Academies of Science, Accidental Death and Disability. And it talked about how many millions of people are out there which are dying at their home because they never make it to a hospital. And so what the report basically came back and said is, if we could find a way to get to them faster and to treat them and do something about it, if we had a national network of people to do it, we could achieve something. And so this 1966 paper set the basis for modern trauma care, and it also set the basis for modern EMS pre-hospital care. And it did these things. It created some uniform laws and some standards. We now had, in 1966, it said we have to have accrediting bodies. Just like we have for doctors, the AMA, we have to have the same thing for medics, paramedics, and EMTs. We have to have better equipment. We're sending people out basically in vans, and these vans don't have anything that we need. We need them to have syringes. We need them to have the right dressings. We need them to have some technology. They need to have communication protocols, and we need to have better training. So those were the four main things that we solved through the 1965 paper. So I want to say that field of EMS really started in the U.S. around that time frame, late 60s, early 70s. We have about 45 years of really good development of where EMS is at, and we're still not where we need to be. Now, just a quick education on EMS. EMS is either run by a for-profit company, and they're basically transferring you between a physician's office and a hospital when somebody's paying them, or real EMS, like the Houston Fire Department, resides under one of the local resources. And so if you look at any of the cities, the EMS will report to the fire department, the police department, or an independent third party, which has been set up to just be the municipal EMS agency. We are a fire-based crew, and that means something because in every fire-based crew, it means everybody that's responding is really a firefighter. They're firefighters who are going to double train to become medics. And so this is the case in many of the largest systems across the United States. But it means something, like from an outcomes perspective, if you looked at just a police-based, you'll probably see different outcomes than if you look at fire-based, and definitely if you look at the independents. And we are the largest fire-based in the nation. We have several 100,000 incidents that they respond to every year, and only 15% of them are fire. So oddly enough, we're set up under the fire department, but EMS is 85% of all calls to 911 where we send somebody out is for a health or medical related reason. And here's some of the stats that Diaa gave me. We have 3,700 firefighters. Those are considered first responders. They're all trained as basic life support, BLS. So they can do CPR and they're basic EMTs. Many of them, I don't know the exact percentage, are trained at the highest level. That's paramedics. Paramedics are roughly the same level of training as nurses, unless there's a nurse in the room who wants to argue. But they're roughly the same. It's thousands of hours of training. They have to do lots of hours of rotation. They can do interventional things. They can do intubation. They can administer drugs on medical direction of the medical director. So they can do a lot. And then in Houston, those ambulances I showed you earlier, we have 63 of those. Plus we have 175 more of other things. And that includes the engines, the ladders, the medic squads, and some others. But if you look, because we're fire-based, if you have an accident where Dr. Sittig goes down at Whole Foods, and he was just eating a sandwich at Whole Foods, and he starts choking, and someone calls 911, well, guess who's going to arrive first? It's probably going to be a ladder truck or an engine.
I hope it's a ladder truck.
Yeah. And then you got all the firefighters running up in their fire gear for this. And so that's what we're dealing with. So what we've really got is a first response system where we're training firefighters how to become real good medical care providers. And here's our challenge, our biggest challenge. Houston continues to grow. And if you live inside Loop 610, you know there's new condos and townhomes coming up all the time. We're doubling the size of the city every 10 years or some crazy number. The number of EMS calls is just growing exponentially. And a lot of these calls, if you look at the research of people like Dr. Bagley or Dr. Linder from the School of Public Health, there's a white paper called Code Red, The Crisis of Emergency Medicine in Texas. We have all of our EDs full. We have 24-hour wait times in some of our worst EDs. And the reason is we're filling them with people that want to come in and do renal dialysis, get medications refilled, and lots of other things. And we're not responding to true emergencies, a stroke, a heart attack, I broke my leg, true traumas and emergencies. And a lot of inefficiency, some low quality, a lot of high costs, and very specialized resources. And then even more of a problem, we've got lack of access to some health care. And so why do we get a lot of these, what we call frequent callers to 911? It's their only way to get health care. And so the ambulances are being largely utilized by people that have no money and have no other way to get care. And so that's a problem for all of us because you might be the one having the heart attack waiting on the ambulance to come, and meanwhile they're somewhere else trying to get somebody off the ground so they get them in so they can get some medications refilled. So this is a problem. And if you look at the issues nationwide, Houston is just leading all of this because we have one of the largest uninsured populations. We have a ton of people that can't get access to care, and we have a lot of these low acuity calls. Okay, now switching gears, what do we think? We think that there's an opportunity for informatics to play a major role. And informatics means a lot of different things to a lot of different people, so I'm just going to make it in basic terms. When we say informatics, it's the use of technology and enabling technology, database, communication platforms, all of the things that surround it, to where we can integrate care between an EMS and a hospital and lots of other parties. And so there's terms that have come out in our field called community-based paramedicine, and mobile integrated healthcare. What we're talking about, our Ethan program, is mobile integrated healthcare. We're the largest mobile integrated healthcare demonstration project right now going on in the country. There's a couple else in North Carolina, one in Virginia, one in Fort Worth, and some others. But we're the largest right now. So as part of that, it usually means enabling technology so that we can get quicker diagnosis and transport. Just real quick, technical definition. Our Ethan program is emergency telehealth and navigation program. So we've gone with this broader definition, telehealth. Telemedicine, though, when you hear that term, it's specifically related to providing remote clinical services to patients. And if you talk to a physician about telemedicine, it means specifically a doctor giving medical care through the use of some kind of platform, someone else. If I want to talk about, well, Dr. Sittig, you got you on my monitor, but I'm not necessarily going to talk to you about your symptoms. Maybe I'm going to talk to you about a host of other things. Do you need access to a physician? Are you having trouble? Tell me about some of the things going on with you. If I want to deliver training, that's telehealth. And so we're using the broader term, and we're not the more narrow term. Although the article we just had published came out in the Telemedicine Journal. So, but we're going to use the term telehealth. It's just supposed to be a little bit broader. So in some places, telehealth, telemedicine is working really well. And they're using it for places that can't have stroke resources, for instance. There's a lot of communities where there is no neurologist who knows how to treat a stroke and diagnose it immediately. So in these cases, if we could dial into a resource and have a neurologist look at my patient with me, and I'm sitting in Brownsville and I'm the only neurologist and I haven't seen but 7 possible strokes this year, versus Dr. Gada here who sees 7 every day, you want to tap into that. So it's been going on in some cases for a long time, but in EMS and pre-hospital care, it's pretty low. So 1970s, we started using telehealth, but really what it was remotely displaying ECGs, the electrocardiograms, and using that kind of telemetry, so objective data only. The subjective data comes in when I'm seeing a patient and I'm saying, tell me about your symptoms, because I really can't understand what's going on until you tell me, I have belly pain, it's been going on for 24 hours, what else do you feel? Well, I feel really sick, nauseous, and I haven't gone to the bathroom in 6 hours, whatever. So that's subjective data. It's not necessarily I can see some quantifiable data pushed over from an EHR, but it's some subjective pieces. So that's really starting to evolve only in the 2000s. And then recently we've started to see some video conferencing, but it's not being used widely. And I'm on faculty here in emergency medicine, Memorial Hermann. We don't use telemedicine, telehealth in the ED, except on demonstration projects at all. And we're one of the largest trauma centers in the nation. So this is still novel. It's not something that's widely used, and especially pre-hospital. Before a patient arrives, it's definitely not. This is the place informatics can play a key role. Just introducing technology which is usable and actionable and is going to add some value. So when we use mobile integrated healthcare, what are we talking about? The use of medics or EMTs to deliver care in non-traditional ways. The specific definition the National Association of EMTs puts out, providing healthcare using patient-centered mobile resources in the out-of-hospital environment. A couple of examples. These are the most common. If anyone says, what's mobile integrated healthcare in pre-hospital? These are the most common examples. Firefighters, as you know, well, you may not know, sit around the fire station a lot of hours. And then they get the call, and they got to quickly get in the ladder, and they get to where they need to be. But a lot of times they're sitting around, and they're training, or they're doing something else, talking, planning. Is there a way we can use those firefighters and medics to proactively go out and do something with patients that might need it, so that we kind of use them more, the utilization rate goes up? And so we've talked a lot about wellness checks that medics provide. They have a lot of specialized resources. Might as well use them, send them out. Or provide vaccines. There's no reason you have to go to Walgreens and pay $30. If we know, and we have you in our database, our image trend patient care record system, and we could see you called 72 times last year, then you're a perfect person for us to data mine and say, we're going to send someone out. Why not? What's going on today? Is there anything we can help you with? Tell us what's happening. Because if not, that's a very low-cost way of getting care. You're down anyway. You get in a normal car, not an engine, which is very expensive to start up, and you drive a couple miles to the patient's house, and you come back 10, 20 minutes later. That's low cost. Activating an entire engine ladder with all the people, the bells and whistles, that's expensive. So these are lower cost ways. And we're going to call it alternative delivery models. That's what they really are. And the goal? To lessen the burden and the cost of non-emergent care, non-emergencies, and provide less resource-intensive providers than the emergency department. If all we do is care for you, pick you up, and transport you to the ED, well then guess what? You get into the ED here at Methodist, CHI, Memorial Hermann, then they're spending tons of resources on you. And if all you really needed was a prescription refill, which oddly enough is a top reason people call 911, is they just needed a way to get into the system, then there's got to be a lower cost way to do it than the ED. And really just to identify another alternative delivery model. How else can we do this? We've been doing this since 1965, same way. There's got to be a better way. And so mobile integrated healthcare is an attempt at a better way. Yes, Dr.
So
Thompson.
they're getting their prescription,
Yes.
but they're trying to do this and getting the system. Yet why aren't they getting it the way they first got it? Is this how they first got it?
And many times it is the way they first got it. They don't have access to a local doctor. And in this program, Diaa might mention it, but we try to set people up with medical homes. Because your emergency department at the nearest hospital cannot be your medical home. It cannot be the place to which you go and get your prescriptions, or the place to which you say, I need to just get a flu shot. There's so many other places that could do it so much less costly than the ED, but they don't have access to it for whatever reason.
For free.
That's right.
So you gotta, you talk about cost, you gotta talk about who pays.
That's right.
Because your politicians wouldn't do Medicaid expansion.
That's right. Yeah. Yeah, and there's all those
When you're
complications.
Has the ACA, have you been able to tell if the ACA's health, I don't know what the data is on the piece of
In terms of the uninsured,
and whether the enrollment means they have insurance versus actual health care. Because many can't afford to use it.
right.
Covers well things, which would cover maintenance prescriptions.
I don't really know the answer to that. I'm looking for, do you know? Have you got any updates on in the last few years?
No, but that is a factor that we're looking at as comparison, because initially, when we started looking at this, our theory or our thought was the majority of people that will utilize the Ethan system will be the uninsured. And our pilot testing was that that's not actually the case. Yeah, that's not what we've seen at all from a policy perspective, is that the utilization has been from people that have insurance as well. So that's what we were starting to see, but that's another kind of element that we want to look at. And I just want to bring out too, to Dr. Johnson's comment, we have seen from comments, because we do get comments that are solicited back that Dr. Lee will bring up, but the reason why people call for medication refills is they have a care provider that takes care of their medication refills. That care provider is out of town that week. So that happens a lot of times.
Yeah. Yep. So lots of complications, and there's several city projects already underway where they're identifying high utilizers of services and targeting them. This is a little bit different way using the fire department, and so good question, but from the overall environment perspective, I don't know that we've seen a ton of changes. But. Okay, so that is mobile integrated healthcare. So I'm going to bring Diaa up and have Diaa talk to you about the Ethan program and hopefully present you with a demonstration.
Thank you, John.
Use that forward button.
So Dr. Langabeer talked about the problem that we're having in the community in Houston in specific and all over the country. And I'm going to talk a little bit about the solution that we here in Houston have developed in the last few years. This program started basically in a different model about 6 years ago. We experimented different models of trying to solve the problem of people relying on 911 for primary care. We had some challenges, and then we developed this model that we now call Ethan that proved to be very successful, and we are working with other urban areas in the country to kind of try to do something similar. So Dr. Langabeer talked a little bit about the problem, but for example, people go to the ER not only because they may not have access to primary care. Some may have insurance, they have a physician they work with, but they want to be seen today because they can't leave work tomorrow, or they want some convenient access to primary care that's after hours, right? So they know they can go tonight to the hospital, they can be seen by a physician, they can leave by tomorrow morning and go to their work, so they don't have to skip a day of work. Some people also go to the ER to get prescription refill because they shop around all ER in the city to get prescription medication they are addicted to. Like some people are addicted to painkillers, and they can show up today at Bentop, get a painkiller prescription. They can go tomorrow to Memorial Hermann, get the same medication, and no one will know because the data exchange is not there yet. So I know a lot of patients that we've seen through this program who are seen at multiple ERs same day or next day or next day, and they are just addicted to some medication. So there are a lot of reasons why people seek primary care or go to the ER by ambulance. There's also a misconception that if you go to the ER by ambulance, you'll be seen faster than if you go on your own or by an ambulance. Just because you get into the ER with the crew in a fancy ride, an ambulance, people think they'll be seen faster, but in fact that's not true. They will be triaged and could be waiting in the waiting room based on their acuity level, just like any other patient. In fact, a couple of weeks ago, we had a patient who called us who was 4 blocks away from St. Joseph Hospital, and he was a primary care patient basically because he didn't have any emergency. He could have easily walked to the hospital, but he just wanted that ambulance unit to get it inside the hospital because he thought he won't be waiting like other people inside the hospital. So those are a lot of people that every day we were working with. We don't know exactly what percentage of our total responses are primary care related, but it's anywhere between 40 and 70%. Now that's really inefficient from our perspective at the fire department because every time we send the unit out, it costs us about $1,600. So you can do the math and see how many millions every year from the tax dollars we're investing in this primary care services that should be delivered at primary care setting rather than at emergency care setting. Sorry. Do you have a
I was just
question?
wondering, is Texas doing anything about tracking the drug-seeking behavior? Because in Kentucky, they had a successful program where they expanded their tracking to additional drugs, such as painkillers. And pharmacists had to check it, doctors had to check it. And they were able to then know that if you showed up one day, got drugs, another day at another place, they had to check all that. They also found out that one pharmacist was writing I think it was 200,000 prescriptions in 1 year. He's no longer a pharmacist.
Right, of course.
Or he was a doctor, actually. He's no longer a doctor in Kentucky. I think he's still in Kentucky, but not exactly where. So that was very effective because they have a huge drug problem. And the unfortunate downside of that was that it was actually causing an increase in heroin addiction.
Right. So Dr. Langabeer and Champagne were champions of the health information exchange in Houston, and they probably have really good answer for that.
Yeah, just so the Department of Public Safety, DPS, controls access to all the controlled substances, and they have a database, a registry, where physicians are supposed to log in to check it before giving another prescription. And unfortunately, because it's so cumbersome, and we need an informatics solution to this, it needs to be integrated in the EHR to where it pops up and says, wait a minute, Ben Taub just provided yesterday, so Memorial Hermann doesn't do it. We don't have that solution. Nobody checks the DPS system. It's got much lower than a 1% access rate per patient in the ED, so that doesn't work. So we tried to get it to where the health information exchange, if you're logged in anyway to see about your patient, it pulls in all available data sources. It pulls in the DPS, and that is, I don't know, it's in planning after I left. I don't know if it's done or not, but it's an informatics problem because the data are there, but no one can get to it.
Right, so the problem wasn't only from our perspective as emergency care providers, was also from the patient perspective, because that patient goes to different ERs every time they need primary care. They see a different physician, they work with different nurses, different providers, their medical record is all over the place. So from their continuum of care perspective, they're not doing they're not getting the best care possible. But we thought if we can connect those patients with primary care setting, same clinic that can act as their medical home moving forward, then they can go back to that same clinic every time they need primary care, see the same physician, the medical records over there, so it's more better care from the patient perspective. So we got funding from the DSRIP. If you know what that is, it's an 1115 waiver that was offered by the federal government to state that didn't expand Medicaid, right? Texas obviously didn't want to expand Medicaid, so they got this option that delivered a lot of funding to local agencies to provide some, or to kind of show some successful models for serving the uninsured and the low-income patients that were supposed to be served by Medicaid, had Medicaid been expanded, right? So this was funded through this mechanism. We started our first patient in December 2014, and so far, 13-month in operation, we've seen about 6,000 patients. So we're going to talk about a little how this program works. This is not moving. Can I touch here?
Oh, no.
Like I'm old school, you can do that. You can touch on
You
stuff.
could try doing it. Is it not working? Okay.
I can just click
Okay.
here. So this program, basically the goal is to reduce the number of unnecessary dispatches for our units, right? Because every time a unit goes out, there's a cost associated with it. We wanted also to make sure those units come back to service faster. So if they want to transfer a patient to a hospital, it normally takes about 70 minutes from the patient's house to the hospital to go back in service, right? But by doing this program, we can put those units back in service faster, where they are able to wait and focus on real emergencies when they come in. So when we have a real emergency call, our staff would be able to respond to this call quicker and faster. So that's from our perspective. Then from the patient perspective, our goal is to connect that patient with a medical home that they can rely on moving forward for their primary care. So next time they need primary care, they're not going to pick up the phone and call 911. And obviously that will reduce the cost for the EMS, but also for the entire healthcare system in the community, and improve the quality for the patient. So that's how the program works in a simple way. It's 5 main steps. So if you call 911, that piece doesn't change. If you call 911, regardless of what your medical concern is, a unit will show up. The reason is some patients might say, I have a headache or abdominal pain, or I'm not feeling well, but they could be having a heart attack, right? So we want to make sure, regardless of what your medical complaint is, someone will show up to your house and check on you to make sure there's no emergency, right? So the crew will show up, they will put their gloves on, they will do their medical assessment in the same way they do for any other patient, right? And then that crew might think, okay, this patient doesn't seem to me like they need emergency care. And I feel comfortable not putting that patient in the ambulance right now and taking them to the hospital. Before this program, or the training for EMTs and paramedics in general, does not allow them to refuse transportation to a hospital for any patient, because the medical training is not to the level where they can say you don't need emergency care. Their main goal is to put that patient in an ambulance, stabilize whatever the situation is, and take them to the nearest care facility. Now what they can do is they can engage a physician that will then evaluate that patient again and make a final determination as to whether this patient needs emergency care or doesn't. All of our units on scene have a device like this. It's like an iPad, but it's military specifications. You can throw it on the floor, put it inside an oven. It doesn't break, it doesn't get damaged. They use it for the medical records, so when they get on scene, the patient information is already loaded on it in terms of address, certain demographics, and chief complaint, why that patient called for an ambulance. And then they will add more information as they do their medical assessment. So when they take their vital signs, they take allergy, medical history, a lot of stuff, they put it in there. And then when they decide this patient doesn't need emergency care, then they connect by video from this device with a physician. And then they will also transfer the record that they have on scene to that physician. So that physician doesn't have to ask the patient the same questions again that those crew in the field already asked, right? So they can see the allergy information, they can see medical history, and they can start with the patient from after those steps. The physician will do the same thing they would normally do at the hospital. So if that unit took that patient to the ER, they're very likely to be seeing the same physician, and the physician will be doing the same thing over this video compared to what they do at the hospital, right? All of our physicians that we work with, they work with us at the city part-time, but they also practice at one of the major hospitals here in Houston full-time. So we have physicians from Bentop, from Memorial Hermann, from Texas Children, from any hospitals, and they share 1 or 2 slots that we have. So depending on what time of the day, we have 1 physician on call. During busy time, we have 2 physicians on call. So anytime, you can either be dialing to 1 station or 2 stations. So that physician will then do their assessment, and they will make the judgment as to what will happen to that patient, which could be, let me jump to this slide first. So it could be where a physician will say, this patient doesn't need a transportation, emergency transportation, and doesn't need emergency care at the hospital. And then in that case, the physician will schedule a primary care clinic appointment for that patient, same day or next day, and will also schedule a cab ride for that patient to pick him up from their house, take him to the clinic appointment. That's our ideal, optimal situation. It doesn't happen as often as we would like it to happen. It's only about 10% of our patients who get this option. It's really the best thing that could happen to someone who calls 911. They will be seen same day or next day at the latest at a primary care clinic that's very close to their house. And then the physician might say, I think this patient needs to be seen at a hospital today, but they don't need to be taken to that hospital by ambulance. So same day care is needed, but an ambulance transportation isn't needed. And that happens about 55% of the time we engage this program. And that way our units were able to go back and service faster and save all the time it takes for them to go from the patient's house to the hospital and hand off the patient at the hospital with the triage nurse, do all the paperwork. It takes about 70 minutes every time. So the third option is where a physician will determine that this patient needs an emergency care and needs it now and needs to be taken by ambulance. And that happens about 18% of the time we use this program. That's where the crew in the field decided or felt this patient doesn't need emergency care, but upon further evaluation by the physician, maybe the patient gave further information or the physician saw stuff the crew in the field didn't see, so they decide, no, this patient does need emergency transportation, and they will ask the crew to take that patient by ambulance to the hospital. And that again happens about 18% of the time. There are some less frequent situations where a patient might say, now that I have talked to the physician and got checked on by the crew, I feel comfortable, I don't really need any further care. Maybe that patient was playing basketball outside and they got dehydrated, and then the crew gave him some water, they rested a little bit, now they feel comfortable, they say, okay, I'll just rest at home today, and if I have any further issues, I'll call my physician tomorrow and go see him. So no further actions will happen to that patient. If you look at the structure for that, how that works, so this is the physician that's sitting at the HEC center where all the 911 calls takes place. They have like a working station where they can see everything. They have like 3 screens, and then they're connecting by this device via video with the patient and the crew. So the crew will give that device to the patient. The patient will hold them and talk with the physician directly, right? And they're also accessing the medical records from the scene. They're communicating with an online system that use data from the medical record, pulls everything for that patient to this medical online scheduling system, where the physician will locate the closest appointment to that patient's house using zip code data from the medical record. And Health Connect, Tiffany and Jim were involved, helped us build that system that kind of integrate all those systems together where we don't have our physicians, physician time is valuable, right? So we don't want that physician to be sitting and entering patient data, demographics, and zip code data or addresses. So that system pulls all data from the medical record, and the physician also has access to this cab scheduling system, which is also online, where they can schedule a cab in 2 minutes. The cabs are surprisingly, they show up really fast. So sometimes they show up like an emergency vehicle. In like 5 minutes, you see the cab showing up. Sometimes before our emergency crew leave the patient's house, the cab is already there, which is really cool. I mean, that kind of raised expectations. So some patients will call us in like 20 minutes. Where's my cab? I'm waiting for my cab. So, and then the physician create their own record. They put their own evaluation for that patient, and then they can specify what happens and the disposition for that patient and the care information. So this is a really large program. We work with over 25 partners on this program, ranging from local to national agencies. Everyone has a really unique role, and they bring in something unique to the table that allowed us to kind of use this program in a way that hasn't been seen so far in the country. We receive calls every day from different urban fire departments in the nation trying to see how they can replicate something like this. We even had calls from Sweden, from Australia, from overseas, because it's really proved to be a successful way of solving the problem of people relying on 911 emergency care for primary care services. For example, a lot of those are clinics we send patients to. We have about 25 clinic locations, mostly federally qualified health centers and charity clinics, community health centers. We also send patients to the primary care clinics of Memorial Hermann System, Texas Children's Hospital. Health Connect helped us build a lot of the IT structure, and their role was really instrumental in kind of developing this in an efficient way from the patient and from the physician's perspective, because the physician can do this in 7 minutes, can finish with the whole patient, do all the documentation, all the taxi scheduling and the clinic scheduling in a fast way, which really helped us kind of introduce this program to a setting where cultural change, where change is really pushed back on, because fire departments have been doing work the same way for 60, 70 years, and now they have different tools, different way of thinking. So if we didn't show this could be really useful for them or really easy to use, we couldn't have this success. So this will complete my portion of the program. What I would like to do is connect with the physician real time to see how that works. So let's pretend I am a unit on scene. Let's see if I can connect my device to the screen real quick. So the IT guy says, unplug it again. Let's see that fix.
Yeah. Yeah, I think this one
Come on.
has potential to grow. Well, oh, there it is.
Okay, so this is the screen. This is a program. It's like a Skype that the EMT crew uses from the field. All they have to do is click on this green button here, and they will dial into a physician.
So while he's doing that, we're using Jabber, Cisco Jabber technology over Verizon communication platform. All of this is secure. All of it's being video recorded, and they're going to keep it for X amount of years. But all of this is HIPAA compliant. So a lot of energy went into from all those technology vendors to make sure they developed something unique and worked for this kind of thing in the field and in ambulances.
So it looks like my connection, because I'm using my wireless connection in this building, may not be optimal. Okay, I think my
Not
Verizon
working.
connection isn't working very well.
Okay.
Okay, but we can try maybe later if you want to.
Okay.
Okay.
All
Thank
right.
you very much.
Thanks, Diaa. Okay, so we might come back to that. We tried to do it over the Verizon network because that's how real life they do it, and hopefully they don't. How many, just since this came up, how many times do you think we have technical communication errors?
So it's on one of the slides
What
you
is
have later. I think it's like 1% where we have
I think
technical
I took
issues.
that slide out, but
Oh,
yeah,
okay.
Yeah,
So
but I don't remember the number.
Yeah, it's about 1% of the
About 1%.
times is where we have connections issue like this. The call dropped or the physician couldn't communicate well with the patient.
Yeah, okay.
But we also work with Verizon, so if we have any area in town where the coverage isn't really good, we talk to them, we let them know, and they send someone out. Sometimes they installed additional towers for us, so even if we have like dead coverage areas, they were able to kind of fix it.
Yeah.
So we're getting better.
Okay, so we're going to go into the last section before we head out, and this is the comparative effectiveness. This is the kind of research that we're doing to compare the relative effectiveness of one program to a series of others, or to at least one. In this case, we have the old model of EMS versus this alternative model. So our real research question for this is how effective in terms of clinical and economic outcomes is this alternative program we've been talking about. We've talked about some of the goals, but we put them into primary outcome terms. And it's basically our number one is greater ambulance and medic productivity, faster back in service times, lower cost, and eventually reduced ED utilization, although we're not going to show you those results yet. Because we're 13, as you said, we're 13 months into this, so we're going to show you some of them. Here's what we did. We've got Image Trend is the patient care reporting record system, PCR. We enroll patients in, they all are in Image Trend. We get extracts of the data, and we're maintaining those here in separate databases. And so we've got a group of the 5,500 to 6,000 patients that we have now, and we've also got a control group. And so it's basically a case control. It's not random. We're not putting them into randomization at the beginning, because I think that in a pre-hospital sense, it's both not necessary, but also it's a study design, and in terms of feasibility, there's lots of other reasons we didn't do that. But we're finding and we're matching on similar types of patients with similar types of conditions to get groups. And we're looking for differences between the groups. And specifically, what I'm going to show you right now is the differences in terms of time to treat, or unit back in service time. Because this is, according to Dr. Peirce, our medical director for Houston Fire Department, that is the #1 outcome that they want to focus on with this. So we did some time and motion type studies. Here's a timeline from when EMS is notified, and it moves forward on this timeline. Medics arrive on scene. These are the averages, 8 minutes. Depart scene in 26, so you can see that means 18 minutes on scene time. And we use medians, by the way, for times because the time is not normally distributed. And unit back in service, basically a minute later, get their final stuff. They click the button, and they're able to go back in service and respond to the next emergency. This is Ethan. This is normal EMS. EMS notified. In our control group, it was the same, 8 median minutes to arrive on scene. Departed scene faster, though, because they didn't have to pick this up, connect through Verizon, show it to the patient, and have the interaction. So instead of 26 minutes, it's 18. So you can see the on-scene time slightly higher. These people then, though, had to get in the car and drive, and the median time took 18 minutes to get to the ED. So arrive hospital ED. By the time they get there, and if any of you ever been to the emergency department and you see medics walking around, there's a lot of things in this handoff, in the transition of care, to make sure that has to happen besides just electronically sending the data, which doesn't really happen. There's typically a printout that's printed out mobily from the medics, given to them, but they hang around to check on status. So that's 81 minutes, and a minute or two later, they're back in service. So we have an 83 on this group of 5,500 patients that we looked at, and 27 on this group of 5,500. So that's a big savings of 56 minutes on average. That means 56 minutes faster back in service. We can send those ambulances and the medics, which if you look at in terms of on a daily basis how many we can respond to, we doubled or tripled the amount of unit productivity. So this is real efficiency. This means if Houston continues to grow, and if we were completely using this kind of technology across all non-emergencies and all primary care, we could do so with the same amount of resources. We can continue to grow and not. So that's what we want to hear, because Houston, of course, is funded through taxes and other things, and that's what we need. So this is proving from an economic perspective to work. So let's look at what else were we looking at besides cost. This was our comparative effectiveness framework. We're looking at a number of things. Not all of them we have definitive answers on, but the first one is mortality. We don't expect to see any deaths because we're looking at primary care related calls. And so in our traditional group, we had none, and in our Ethan, we had none. So no mortality, no deaths, and no real reported adverse events, like somebody stroked out and we didn't expect it, or someone was having a heart attack and we thought it was primary care. We didn't have any of that. The disposition patterns, though, we're seeing a major change. This is where we saw a 95% ED transport. 95% of the time a crew arrives on scene, they're taking you to the hospital. That's how we get to the 83 minutes. Here, like Diaa said, we're at 18% ED transport by our own units. More people might go to the ED, but they're doing so in the other ways that he mentioned, through a taxi. They referred themselves. Most of them, though, many of them are going to our affiliated clinics, so we're sending their primary cares through taxis. So, but a major drop in terms of the ED transports out of these. Patient satisfaction, we're doing follow-up calls on a subset of them. Normal EMS, we're getting about an 87% satisfaction. We're averaging about 85% at the last time we measured it, so slightly different. And it's to be expected, because if you really just wanted to go to the ED, and that's why you called, and you didn't go to the ED, well, guess what? You're going to be a little unhappy with the outcome. But we didn't feel it was clinically necessary. And you didn't die from it. There's no adverse event, and costs went down. So we were hoping for neutral satisfaction. We didn't expect it to go up too much, but this is where it's at the moment.
Is that significant?
Statistically significant?
I would think it's not.
We don't have enough cases because of the subset we're looking at, but as we continue to do it over the next year, we might. But so it's not at the moment.
So another quick question.
Yes,
So
sorry.
when a patient, when you determine a patient doesn't need to go to the ED and they still want to be transported, do you still transport them? Or do you still?
No, most of the times, if there's times when they can refuse and insist, and I guess you're taking them in rare instances, but typically they'll say, we don't think you need to go, and they give them a taxi voucher. I think if you want to talk about the exception.
Right, so from a legal perspective, the physician can refuse to transport the patient by ambulance or take him to the ED if that's not medically necessary, right? But sometimes if the patient has a reason why they want to go to the hospital, but sometimes they are discharged from the hospital the same morning and they want to go back to pick up their results. So they insist and they become maybe a little violent or something, they want to go to the hospital. So sometimes we honor the patient request and take him to the hospital, but we schedule a cab for them instead of the ambulance. So we still take him to the hospital, but we take him by cab.
So we talked about the unit back in service time, unit productivity. If you look at, we're doing simulation models based on this for our analyses. You can see we could do a lot more turns, a lot more productivity. And then the average cost, this is what Diaa said, we're averaging every time we send out a typical unit, $1,600 per unit. In this case, including all the technology, and there was a lot of these tough pads that were bought. There was Cisco technology, there's a lot of others. We had about $600,000 in capital startup costs, plus we have programmatic costs, operational costs that we added on. Even when we look at that and factor it out over the number of incidents, we're less than 1,000. So we're dropping costs. Costs are coming down. Definitely the units are more productive. A little change in patient satisfaction, a significant drop in who the EDs are seeing now. They should be starting to see a lot less primary care related, and no adverse events from all of this. So this is our comparative effectiveness model. We're 13 months into it. Our goal is to get through the next year, hopefully have really good data, and just to continue to monitor, make sure nothing changes, but we haven't seen significant change in these numbers over time. Oh, I did keep it in. You're right, Diaa. Okay, so this is the disposition percentages, and this is based on the data we have. There's like 6,000 right now, but we have 5,570. The analysis was based on, I think. And so you can see these are just what we talked about. EMS transport was 18%. By cab or self-transport, you still went to the doctor, but you didn't do so in our ambulance. And then you could see these other ones where patient refused.
Patients were in the control group?
About the same number, so we're matching. It's a matched group. So, I don't know why I had references, but maybe that makes sense. Here's some of the references we used in some of these things. We've published so far in the Journal of the EMS. We published in Telemedicine, and then we have an article pending now in Prehospital Emergency Care, which is our highest impact factor. So we're starting to get a lot of our preliminary data out there. But I want to end with this. So we put a lot of technology together. There's a lot of informatics that went into this, both the database, the technology, communication, and the analyses of all of this. And we have 5,500 patients. It may not seem like a lot when you're looking at 200,000 to 300,000 across the city, but that number is slowly growing over time. So we're going to eventually get this to where it's much higher diffusion of our technology. But we're seeing really good improved results, and from a comparative level across all those outcomes, not just on one outcome. And this really equates to greater capacity to respond, and in our case, greater capacity is less cost. And like Diaa had mentioned, we're starting to also see a lot of other interest in this throughout other cities. And so not only is Houston going to start to evolve this, but we're going to start seeing other cases of where this is hitting the literature. And hopefully, if you're a student or a faculty member, you'll be able to participate in one of these projects that are going on throughout the country. But in order for all this to work, I just want to point out one policy thing. This is based on really old reimbursement models where no one's been in an ambulance really as a patient in this group at least, but if you were to be, you're going to get a bill. And in that bill, most of the time, the people that we treat can't pay. And so there's a lot of very low capture rate on this. And so we try to bill the insurance company if there is, and there's low rates on that too. In order for this to work, we have to have telehealth be reimbursable in Texas. In telemedicine today, if it's performed inside the state, is a questionable service. It has to be set up, and it's very specific to the individual care plan. But it's never been set up, as far as we know, it hasn't been used for pre-hospital care at all. So in order for this to really work, I mean, even though the costs are lower and people may want to do it, Wouldn't it be great if on top of that, we could bill for that and get a higher reimbursement? Even if we got $500 back, wouldn't it be nice if Blue Cross reimbursed us for that, or Medicaid or someone else? So this is really something that we're tackling as one of the next phases, and we're going to be looking at doing some working committees with the American College of Emergency Physicians and AMA and the Texas Medical Association to see what we can do here. And so we're really trying to drive reimbursement changes to allow technology to work in pre-hospital care. So that's our presentation. We have a couple minutes for questions, if anyone. Yes, ma'am.
Thank you for your presentation. I really enjoyed it.
Thank you.
I was wondering though, is it really expensive for the basic fire department to hire a physician that would actually like go out and dispatch with them and like assess the patient on scene and all of that?
So there's two kinds of direction that you always have to have physicians direct medics in every county and city in the nation. So we're always going to have a level of physician cost. It's either online or offline, and we're primarily offline to where we set a whole bunch of policies in place, but we also have an online component. So we always have a physician that's available if needed. This is added. We have added physicians, like I think we're up to 16 physicians. These are not full-time physicians, though. We're not employing full-time people and saying, instead of working at Herman, come work for us, because that would be a very costly approach. So we're trying to get people that want to do 1 or 2 shifts, and in that case, it's really a lot less expensive. So they're boarded emergency medicine physicians, but we're not, this is not, we're factoring all of that into the costs. When we say we're about $1,000 cost to run, all that's in there.
So currently the physicians have to sit in a certain building to receive those calls, but we're building a technology where they can take those calls from anywhere, from their house, from their offices, from their different jobs, so we can reduce their reimbursement. So instead of that physician spending 10 hours in that building and getting only 5 calls, maybe they can sit in their office, do some other work, and get paid for those 5 calls only when they come in. But it's a lot of security issues that we need to build in the technology to allow them to take those calls from places other than a city-secured IT structure.
Right, which will help further lower costs for us. Yes, Dr. Thompson?
How does this interact with private ambulances?
So I think that's a good question. It does. This program today does not. It's only talking about.
It does, right, in some sense, because I don't know how that works here, because you're competing in a sense with them. My guess is, from a profit motive, they want to transport at all costs.
So the 911 system only activates our Houston Fire Department.
Okay.
So if you call, am I right?
Right, the private
I wanna make sure.
ambulances can't take 911 calls.
Right.
They can't do emergency transportation. They only transfer patients maybe from their long-term care facility to maybe dialysis service.
So if you see an accident on the road,
It's always
It's always HID.
Houston,
Or Harris County EMS if you're outside of
I see a lot of
that.
private, and I didn't know if they,
Yeah, they're pretty much, if you see a Ryan ambulance, and well, some cities, I believe, do outsource to the privates, like Acadian does that, and so
Right,
some
yeah.
cities outsource to them. Here in Houston, though, it's municipal based. 911 has to activate through us, so we're not really competing per se. Yes, ma'am.
I have 2 questions. One is, do you have any enhanced assessment modalities? I'm thinking of ultrasound, perhaps that you're videoing to the physician. And then the second question, it's not a question, it's just really this question. I believe, is Texas reimbursing telepsychiatry?
I don't know the answer to that, and you might be right.
I was saying you could get a psychiatrist and.
Yeah.
There you go.
Right. Yeah, I don't know. I'm kind of specialized in this area. Right. We think different. You're crazy. And now we can charge. It's something to look at, though. That's part of our next step, is to really figure out what does it take to do it. We just know it's very limited and it doesn't have high penetration.
And then it gives you like a model to follow as to getting further telemedicine reimbursed.
That's right.
But back again to ultrasound.
Yeah. Do you want to answer that? I don't think
the
so.
physicians can ask the crew on scene to do additional tests, or maybe take a new set of vital signs 15 minutes after they took it the first time. But if they can't do like kind of sophisticated testing like ultrasound or something like this, but they can do some more minor testing.
Do you commonly do that in the field anyway? I mean, I know you do EKGs.
Right, so I don't know exactly what are all the testing services, but I know they have EKG, they have some other stuff.
Yeah. So, anyway, I think it would be really cool. It might be helpful to be able to transmit that by video.
Absolutely. Yeah, it's a good idea. Any other thoughts, comments? Okay, well, I appreciate you guys coming to hear about what we're doing with EMS in Houston. Thanks a lot.